Hello and welcome to our very important discussion today on cystic fibrosis. What is cystic fibrosis? Cystic fibrosis is an autosomal recessive genetic disorder. So that's the first key concept. It is autosomal recessive. And even though the name is cystic fibrosis, it is much more than the formation of fibrotic scar tissue cysts. But the reason why it was called cystic fibrosis is because they first found its clinical implications on the pancreas that manifest as cysts that are fibrotic, cysts that are made of scar tissue. But it's actually more than that. But one of the clinical manifestations of cystic fibrosis is the formation of fibrotic cysts on the pancreas. But trust me, cystic fibrosis does not leave the lungs alone. Cystic fibrosis does not leave the integument, the skin alone. Cystic fibrosis does not leave the sinuses alone, and this cystic fibrosis does not spare the kidneys and the liver. In fact, cystic fibrosis can even lead to male infertility. So let's talk in depth and let's uncover and unravel the mystery behind cystic fibrosis. So up to this point, we have learned that cystic fibrosis is an autosomal recessive disease. Do I need to say that one more time? It's an autosomal recessive genetic disorder. So if you are a carrier if you have the allele, the small allele for cystic fibrosis, you are a carrier, but you will not have the disease. So what is cystic fibrosis? The issue with cystic fibrosis is it is a problem of transmembrane transport of the electrolyte chloride. So if you look at this illustration that I have here right in front of you, these are two separate illustrations of normal tissue. 1, 2. On the top is 1, on the bottom is 2. So what is 1 and 2? 1 and 2 are both normal tissues, normal different tissues. The top tissue is the lumen, that shows you the lumen of the sweat duct, and this is the epithelial tissue that is facing the lumen of the sweat gland. So this is the sweat gland, and on the bottom is the airways. On the top, the sweat glands, on the bottom, the airways. So how do they look normally? How do the sweat glands and the airways look normally? This is very, very, very important. How do they look normally? They look normally like this. There are two kinds of channels that are on the surface of the sweat glands. The first channel is the red channel known as the chloride channel. That is the CFTR channel. CFTR channel, known as the cystic fibrosis transmembrane regulator. So what does this channel do? This is very important. Does the channel bring the minus chloride from the lumen to the inside of the cell, or does the channel throw out the minus chloride from the inside of the cell to the outside? So lumen is the outside, mainly the core of the sweat gland, but these are the cells. So we bring chloride in. So look at where the arrow is pointing for the red chloride channel. The arrow is pointing to the inside. So the directionality is very important. That in normal tissue, the chloride minus ion is being absorbed, brought in, dragged inside the cell from where? From the lumen to where? To the inside of the cell. Through who? Through this chloride channel that is known as the CFTR, or the cystic fibrosis transmembrane regulator. There is another orange channel. Don't forget about it. That is the Na plus channel, the sodium channel. This sodium channel brings in sodium in the same direction as chloride. So sodium follows chloride. That makes perfect sense because there is a electrical gradient. Since the minus chloride is going in, there is minus, 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 minus inside the cell, then all the sodium plus plus on the lumen is going to try to come into the cell. So what is the name of the sodium channel that brings in sodium from the lumen to the inside of the cell? It is not called CFTR, it is called the ENaC. ENaC, E-N-A-C, electrolyte sodium carrier. That is the name of the channel. So what did we learn so far? That normally in the sweat gland, we have two types of channels. A chloride minus channel known as the CFTR that brings in chloride to the inside of the lumen and brings in chloride to the inside of the cell from the lumen. And so does the ENaC, the electrolyte sodium carrier, brings in the positive cation. So sodium is the cation and chloride is the anion because it's minus. And we bring in the sodium to the inside of the cell. This is very, very, very important. Now we're done with the sweat gland. We're gonna see what's gonna go wrong when we move on to the next illustration. But for now, all we need to know is that how do things look normally? They look normally like two channels. One of them is the cystic fibrosis transmembrane receptor channel that is responsible for bringing in the minus chloride from the lumen to the inside of the cell. And there's the ENaC that brings in, this is the sodium channel that brings inwardly sodium from the lumen of the sweat gland to the inside of the cell. We're now done with the sweat gland. Now let's move into the airways. Let's move into what happens in the lung. The lungs do also have a lumen and they have cells, but the directionality is not the same. That's the very important first concept. Up here in the sweat gland, chloride and sodium are both brought inwardly. But in the airway, it is only the sodium that is brought inwardly. So we only absorb sodium in the airways. So in both cases, the sweat gland and the airways, sodium is getting reabsorbed. Sodium is brought in, absorbed. But the chloride only in the sweat gland is being absorbed inwardly, but in the airway, it is thrown out. It is secreted. That is very important for you to understand that only in the sweat gland do we have chloride coming in with sodium, but in the airways, sodium still comes in, is reabsorbed, but chloride is not coming in with sodium. It is thrown out in the opposite direction with, is thrown out to the lumen. And there is another thing to learn about the airway. That is, there's a third player, and that is water. There is no water that channel that we're dealing with in the lumen of the sweat gland. But in the airway, there is water. So water is always moving with sodium. Remember, we see this even in the kidney. You secrete the hormone aldosterone. What does aldosterone do? Aldosterone is going to reabsorb sodium, and water follows sodium because water is a versatile solvent that follows the solutes to dissolve them. So here the same thing. So in the airway, sodium moves in, chloride is thrown out, and water follows sodium to the inside of the cell. And you see that there is obviously in our respiratory system, there's a lot of mucus. This mucus traps these microbes and traps the necrotic debris and traps all of the pollutants that come into the airway. But this mucus has to be full of water. This mucus has to be full of water. So the problem with cystic fibrosis is, what is the problem with cystic fibrosis? Well, we said that the channel responsible for the chloride is this red one, even though it's bringing chloride in different directions when we compare sweat gland to the airway, but we still call it cystic fibrosis transmembrane receptor. So don't think that because in the sweat gland chloride is being brought in, but in the airways chloride is thrown out, that chloride channel must have a different name. No, it's the same one, but it's working in two different directions. That's a very important concept. So in cystic fibrosis means there's a genetic defect. That chloride channel is gone. No chloride channel. So no red channel. So in the sweat gland, no red channel. In airways, no red channel. So everything else is going to stay the same. So a patient with cystic fibrosis is not going to have a chloride channel, so chloride is going to stay behind. There's going to be a lot of chloride here. In the airway, no chloride channel, so there's going to be a lot of chloride in it. It's going to be a lot of chloride inside the cell. Because remember, chloride goes into the outside in the airway and comes into the inside in the sweat gland. Since there is no chloride for the sweat gland, there's going to be a lot of chloride in the lumen. But for the airway, there's going to be a lot of chloride not in the lumen, not in the mucus. It's going to be inside the cell. Very important for you to know that the cystic fibrosis transmembrane receptor, how does it move chloride depending on where? So now let's look at the diseased. Let's look at the disease cystic fibrosis. If you look at the cystic fibrosis cell, if you compare the normal cell, it has both channels. The red CFTR, the cystic fibrosis transmembrane receptor, and the orange ENaC, the sodium channel. But if you look at the cystic fibrosis patient's sweat gland, do you see any red cystic fibrosis transmembrane receptor compared to here? No, it's gone. There's an X. It's not there. So there is no cystic fibrosis transmembrane regulator here. But is there a sodium channel? Yes, there is. And it's going to be closed. Because remember, the movement of sodium to the inside of the sweat gland was based on the electrical gradient. The chloride minus goes in, the sodium plus follows it. But here, since there is no chloride, transmembrane receptor to bring the chloride inwardly, so chloride stays behind and sodium stays right next to it. That's why on the surface of the sweat gland and the epithelial tissue of the patient with cystic fibrosis, you will see chloride and sodium sticking together, and that's salt. That's why the mom, when she just gives birth to a baby who's suffering from cystic fibrosis and she kisses that baby, what does she taste on her tongue? She tastes salt, because the baby has so much salt due to the absence of the cystic fibrosis transmembrane receptor. That's as far as the integument, the skin. Because remember, we have somebody on the bottom, and that's the airway. Now let's compare the airways. We said in cystic fibrosis, the sodium receptor is not affected. So you see sodium in a normal cell, sodium channel in a normal cell is right here, ENaC is here, orange, ENaC is here, and ENaC still in the cystic fibrosis. But look at the chloride cystic fibrosis transmembrane receptor that's supposed to throw out chloride. In the healthy cell, it's there. But in the cystic fibrosis body, it's not there. So that means we will have a lot of chloride inside the cell. And since we have a lot of chloride inside the cell, who's gonna follow from the lumen to the inside of the cell? The sodium is gonna follow the chloride. And if sodium moves inside the cell, who's gonna follow sodium? The water. So water gonna flow in. So if you take a sample of the mucus from a normal person, healthy person's airway, then you take a sample from the mucus of a patient with cystic fibrosis, and you compare their content, you will see that the healthy person's mucus has a balanced amount of chloride and sodium and water. But if you look at the cystic fibrosis patient, you will see that their mucus has no chloride because chloride is not being secreted from the inside of the cell to the mucus. So their mucus will have no chloride, and their mucus will have little to no salt, little to no sodium, and it will have been devoid of water because the water is already following the sodium, the sodium is running to the chloride inside the cell. So their mucus is so viscid, their mucus is so devoid of water and sticky. That's why it's illustrated here all in black. So they're always coughing. They're coughing because their mucus is so thick and viscid. Viscid, viscid, very viscid, and has no water, and that clogs the airway, impairs even the flow of air. So it's very important for you to understand, what does the cystic fibrosis transmembrane receptor do in the healthy body? In the sweat glands, it brings in chloride to the inside of the cell. So in cystic fibrosis, the chloride cannot be brought in because the cystic fibrosis transmembrane receptor is not there. Their skin will be salty. And if you look inside in the airway, chloride is being thrown out, sodium is being brought inwardly. But in the cystic fibrosis patient, since there's no chloride, chloride remains sequestered inside the cell, and sodium follows to the inside of the cell, and you have water following sodium. So the mucus is going to be very viscid, and is going to be very thick and it's going to be very viscous. So now we understood what goes wrong. So how do I tell a baby has cystic fibrosis? They will have salty skin, and their mucus will be devoid of water. So do we only have mucus in the airways? Of course not. We have mucus in the gallbladder. So their gallbladder canaliculi will be blocked also. That's how cystic fibrosis affects the gallbladder. It affects also the kidney. Cystic fibrosis, this clogging of the mucus causes the liver cirrhosis. Also the pancreas. The pancreas is affected, and that's how we first learned about it. Then the pancreas of patients with cystic fibrosis will have cysts that are made of scar tissue and fibers. Also, please remember that this mucus that is devoid of water, this mucus that is hypercoagulable and thick, it is the perfect environment for bacteria and microbial infection and Staphylococcus aureus. Staphylococcus aureus loves a patient's mucus who has cystic fibrosis because that is the proper place for their growth. That's why these patients with cystic fibrosis are always suffering from lung infections. In fact, sometimes dying from it because the bacteria colonizes. Staphylococcus aureus colonizes in this thick mucus. That is in the lumen of the airways. So now we understood that there is this generalized mucus that is very thick and very viscid. So now let's look at the clinical manifestations. Let's look now clinically. Let us now look clinically what happens in the body. Now we learn that when the receptor is not there, what happens to the electrolyte chloride? And based on what happens to the chloride, we learned what happens to the sodium and water. Now let's look at what happens to the body. let us now look at what happens to the let us now look at what happens to the body. So, number one, sweat glands. So you see the patient with cystic fibrosis has a lot of sweat on their forehead. So there's increased sweat and sodium chloride concentration on the integument, on the skin. In addition, sinuses, there will be sinusitis because the mucus is also in the nares, in the vestibules. The mucus is always going to be in the nasal airways and is gonna become a very mucusy and very area for colonization of the bacteria. So the patients, in addition to being sweaty all the time, they will always have sinusitis, inflammation of the sinuses that are full of and clogged with this mucus of cystic fibrosis. In addition, like we said, the patients will always have lung infection and inflammation. They will have Staphylococcus aureus and Pseudomonas infections, and they sometimes will have bronchiectasis when things exacerbate severely. So this mucus also affects, as we've seen, the skin, the nasal airways, and also the lungs, causes infection, fosters an environment for the colonization of these Staphylococcus aureus. Then the cystic fibrosis will also cause liver fibrosis and liver cirrhosis. And don't forget the pancreas, because that is where we first discover cystic fibrosis, and it will make in the pancreas cystic fibers, and it will cause exocrine dysfunction, because remember, the pancreas is 2 in 1. The pancreas is an endocrine gland and an exocrine gland. Endocrine gland meaning it's a gland that will secrete its endocrine substance in the blood, but exocrine does not secrete in the blood. It secretes in a duct. And remember, who's clogging the duct? Who's preventing the outflow of the exocrine digestive enzymes from the pancreas? It is this mucus, because of cystic fibrosis. So that causes defect and stress in the pancreas that will become a form of inflammation and cystic fibrosis, and that will lead eventually to diabetes and autocatalytic destruction of the pancreas, because the exocrine secretions are meant to go and digest the food that we eat, but because the mucus of cystic fibrosis is clogging the exit ways in the exocrine glands of the pancreas, now this degradative enzymes, instead of degrading and breaking down and digesting and metabolizing food, they're going to end up destroying an autocatalytic destruction of the pancreas, who's secreting them. And the intestines are also going to be obstructed. So patients, these babies who have cystic fibrosis, their large intestine is going to be engorged with a huge amount of fecal matter that is very greasy and very large in size. This is called meconium ileus. Very important to know this, meconium ileus, because the mucus is preventing the capacity of the large intestine to reabsorb the water. And the small intestine also is not left alone or spared by cystic fibrosis. The cystic fibrosis prevents the small intestine from reabsorbing the fat-soluble vitamins, like vitamin K. So these patients cannot absorb vitamin K from the intestine, and therefore vitamin K is important for blood clot and the blood clotting. So these patients can have problems clotting in their blood, and then they will bleed endlessly if they are injured. And lastly, for the males, the cystic fibrosis causes male reproductive tract damage and causes infertility and azoospermia, and there is bilateral obstruction of this vas deferens, bilateral obstruction of the vas deferens. So it's a multi-system defect, this cystic fibrosis, even though it was discovered only as cyst in the pancreas, but it's actually a generalized defect. Thank you very much, and I hope this was a clear and important lecture. Thank you very much.